dark side of the Force is a pathway to many abilities some consider to be unnatural.
The only disclaimer I've got is that I have been known to use screw fixation of the proximal radius, and it's not just coincidence that Professor Van Riet is wearing black and I'm wearing white. I would suggest you don't get seduced by the dark side of the Force. It's very easy. It's very, very easy when you're faced with these sort of problems. This was one of my cases. So how can you show whether plates are better or screws are better? Well, you can show whether it's biomechanically better. You can show whether it's clinically better, and we all know the triad, not the triad, but the pyramid of evidence-based medicine. But at the end of the day, as far as orthopedic surgeons are concerned, it's really, is it better? Is it better in my own eyes? Is it better than sliced bread? You could base that on a case series, on a randomized controlled trial, or a meta-analysis of randomized controlled trials.
And your wallet.
Nick, give him your wallet.
What for?
He's got a knife.
That's not a knife. That's a knife.
Yeah. This is a professor of hand surgery in America. This is what you can find on the internet. He's talking about displaced, in his words, radial neck fracture, which was limiting pronation and supination. And I must say, there's not a lot of displacement on that radial neck fracture. Here's his dissection. I've muted him for to keep it anonymous. But I've no doubt that that 2 or 3 millimeters of impaction and that little bit of angulation really wasn't limiting this patient's supination. What this patient needed was someone to give them a good talking to, boost up their analgesia, and encourage them to get it moving. And so, in fact, plate fixation, which is what they did in the end here, or screw fixation, was irrelevant. I don't think this radial head needed anything fixing. This certainly wasn't a knife. It got plated, and that's what sort of finally happened. We see now another case. This is presented by a French surgeon. And we see clearly there a radial head fracture that's displaced, with the radial head completely displaced. And in fact, when he goes through the EDC split, you'll see that it's herniating through EDC. I doubt that radial head was blocking the rotation, to be honest. Again, all that patient needed was analgesia and to get that stump of the radial head removing. Nicely demonstrated here, where you can look at the bare area, make sure your plate is in the proper position. And if you put your plate in properly, it doesn't impinge in pronation and supination. And you can see that fluoroscopically. You may be aware of the classification systems. Mason of 54, Hotchkiss of 97, and Mason Mayo of 2008. And I must say, this is one of my favorite classification systems. Yeah, can you believe he was writing back in 2008? He doesn't look that old, does he? You probably shouldn't highlight your adversaries' publications, but this article by Roger, co-authored by Bernard Murray, was a great article. It brought us in this concept of when you look at radial head fractures, radial neck fractures, you can't just look at the radial head or neck fracture. You need to take it in context of the whole elbow injury. You know, you have to treat the whole joint, the elbow, not the whole patient. And particularly if there's ligamentous injury or instability. And so I like this classification. It is, however, based on the Mason classification of 54. That's a long time ago. And he talked about the 3 types, and in black and white, that's what they read like. But you need to see it with your own eyes, don't you? Well, I certainly do. And if you have a look at it, that's what Mason said was an undisplaced fracture. That was a type 2. And I must say, to my eyes, that still looks like an undisplaced fracture. And that's a type 3. He actually didn't show us the fracture. He just showed us where he chopped it out. Not many people nowadays are just chopping out the radial head. Most people are preserving it if we can, and then replacing it if you have to. But in his article in 54, he talked about this marginal impaction fracture, which he then ended up chopping it out. And to be honest, looking at that fracture, in retrospect, I think the patient would have been best served with just leaving it in, getting a stern talking to with good analgesia, and told to mold that radial head himself. Why do I talk about this? Well, this is the Swedish paper, one of the long-term studies, 1969 to 79, a totally different world, pre-COVID. Everything will be defined pre-COVID now. With good follow-up for those that were left in Malmo. Few people were excluded, but not a bad study considering it is back in the late 70s. They found 49 patients, 19 years post-injury, with some moderate displacement. And there's the radiographs that they showed us. And we see there the displaced radial head fracture, and I've highlighted it. I haven't touched it up with any Photoshop. Quite a significantly displaced radial head fracture. Of those 49, 6 had a delayed radial head excision, but nearly all of them had a beautiful outcome. Good range of movement, inflection and extension, and very little loss of pronation and supination. And so this article highlights to us how well radial heads can do, even if they're moderately displaced.
This laundry powder keeps my coat clean. Powder keeps my coat clean, and so does this one. You know, it's funny. You put on a white coat and everyone thinks you're a doctor.
You're not my doctor.
I'm not anyone's doctor. Hi.
Yeah, very much like that advert by Oldie. I like this classification, but I like this classification more. And the reason being is, it's obvious barn door. The case on the right by the French surgeon, that's a knife. The case that was done by the American surgeon, that was not a knife. That didn't need to be fixed. Now watch out with evidence-based medicine and whatever you read. You can't always believe what you read nowadays, can you? This is an article from The Lancet, so you probably can believe that. And what The Lancet is telling us is that you can't believe what you read, which is an interesting irony. But just when we go up this ladder of evidence-based, it's not always perfect. So let's have a look at the evidence, because that's how you tell whether plates are better than screws. So the biomechanical study. This was a comparative study looking at radial neck fractures treated with screw fixation, published in 2015. And they concluded stiffness of both constructs was similar. Screw construct was stiffer. That doesn't always correlate for improved outcome. And they basically concluded at the end, well, plate and screw constructs are appropriate. 2 oblique screws might be preferred for simple transverse fractures requiring less exposure, and the implant is buried. Okay, now that's what the text says. So let's do the orthopedic test. Does it look better? And just to my eyes, those blue lines look a lot better than the red lines, and that is true. If you have a look at the blue lines and the red lines, the screws win. If you have a look at the modes of failure on your right-hand side, that right cadaver specimen, that plate has fallen apart, whereas the screw has just angulated or translated just a little. So the eye test, screws win. The dark side is winning at the moment. And they go on with that conclusion to conclude that screws are better.
One other thing, Mrs. Halpern.
Yeah, one other thing. This is not the same paper, slightly different paper, but again, looking at cannulated screw fixation. And whenever you're doing a presentation or whenever you're doing photos for a publication, you make sure that there's no blood in the wound, and you make sure that your drawings are nice and short, and that your drawing is shorter than your actual incision. And then you don't show the final picture, because in this same paper was this paper. So that's a minimal invasive fixation of the radial head with screws, but they've done a maximal approach. So yes, for their publication and to catch your eye, they show you these pictures first, but they leave that one right to the very end. And this came from this sort of publication. This is also a cadaver study. Look how beautifully crossed those screws are. Look how beautifully positioned they are. It's actually quite difficult sometimes through small holes to get those screws absolutely perfect.
There's one thing I almost forgot. Do you have another minute?
I think we do have another minute. So let's go back to that paper, this beautiful cadaver paper that shows that they're similar. If you just believe what you see, you'll think that the plates did worse than the screws. In their text, they talk about the screws being countersunk, which is important, and the screws being distal to the proximal radial joint. And in fact, here they're taking it through the bicipital tuberosity. And ask you not to make them proud by more than 1 or 2 millimeters. And certainly on this X-ray on the left, those screws are no more proud of that bicipital radial tuberosity. But if you have a look at their actual cadaver specimen, their best specimen, the one they took a photograph of, there's at least 4 or 5 screw threads that I can see pointing towards us. Because it's never always in the plane of the X-ray when you're taking the X-ray. And so that almost certainly is going to be irritating the owner. I don't have case reports yet, and I'm sure we will see them. Case reports of screw fixation leading to heterotopic ossification at around that level. Because if you're going to use long screws, there's not a lot of room between the ulna and the radius. And all you need is 3 or 4 millimeters. And if you scratch the ulna or the radius from either side, you will get heterotopic ossification. And if you get heterotopic ossification, you will get loss of movement. Another study, biomechanical study, sawbones, looking at 3-part fractures of the radial head. There was no significant difference between fixation of 3-part radial head fractures with screws versus plates. Further study and clinical studies need to be done, but basically it's telling us that screws are the same.
One other thing.
As plates. Always one other thing. There's a paper talking about Mason 3s, and when you talk to me as an elbow surgeon about a 3-part fracture of the radial head, that's what I see. I see 3 parts to the radial head. If you have a look at this sawbone model, to me that's a 2-part fracture of the radial head. They've split that radial head into 2 parts. They've counted it like a proximal humerus. They're shoulder surgeons here. This isn't a 3-part fracture. This is a 2-part fracture. And you can see that there's quite a lot of head and neck. If you break your radial head in a 45-year-old, 50-year-old, there's normally not a lot of neck. There's normally not a lot of head, to be honest. And so the fixation in that sawbone model would be totally different to the fixation in the human model. And so you can't really extrapolate these biomechanical studies, because the one on the left is a knife, the one on the right is not a knife. Anyone can fix it. Let's have a look at the clinical studies. Remembering that you can do well with non-operative treatment, we'll have a look at the clinical studies for plates, for screws, and comparative studies. And this is an international meeting. So here's a German paper. I don't read German, but I can look at the pictures. And you can have a look at the demographics. They're in the ages of 40, 50, 60. You can see the pictures showing proper radial head fractures, displaced. The 3D CT didn't come out too well on the final publication, but clearly a complex fracture of the proximal radius put together beautifully with a low profile radial head plating system and with good outcomes. They found 21 patients, 50 years of age, 12-month follow-up, good outcomes with good range of movement, particularly focus on your pronation and supination, 70 degrees and 63 degrees. Another study, published 24 patients, found over 3 or 4 years, follow-up of 30 months, Albert performance scores of 98, significantly displaced radial head fractures. So these were knives. These needed to be fixed. And if you have a look at the graph of range of movement, near normal flexion extension as you would expect in most radial head fractures, and beautiful pronation and supination, only a loss of a few degrees. If you have a look at the screws, well, there's one case report. Well, that's pretty good. In the 17-year-old, published in 2018. And this is what most people are using as their justification to fix the radial head and neck with screws. Beautiful x-rays, passes the orthopedic eye, looks better than sliced bread. And the rest of it was a surgical technique article done on a cadaver specimen. Doesn't really fit very high on that pyramid of evidence moving up the pyramid.
Oh, Mr. Chase, one thing about that accident.
Always. Yeah, about that accident. Let's have a look. That was a 17-year-old. So totally different population to the 50-year-old. If you have a close look, these are the radiographs from that presentation. You can almost see the fascial scar of the medial epicondyle. This isn't a 17-year-old, nearly 18, 19. This is a 16-year-old. Fascias are still just about closing. The quality of that bone would have been excellent. No comminution of the radial neck. Is that a knife? I'm not convinced that is a knife, to be honest. The only comparative study I could find was this study, again looking at radial neck fractures, displaced. So reasonable displacement on those radiographs, reasonable displacement on those radiographs, treated with plates and screws, non-randomized study, managed to get 29 in each series somehow, and follow-up of 12 months. And this was their abstract. The mean functional scores did not differ significantly between groups, but the mean range of forearm rotation each group was significantly better in screws than the plate group. I read that wrong. That suits Professor Van Rick, doesn't it? Screws are better than plates. And although not statistically significant, the screw group had a lower incidence of heterotopic ossification than the plate group. And so if you just read the abstract, Yes, you might be seduced into the dark side of going and use screws.
Just one more
But
thing.
as always, just one more thing. Oh man, I hate it. You can never believe what you read. So let's read this a little closer. I'll focus on the parts I want to focus on. Although not statistically significant, the screw group had a lower incidence of heterotopic ossification. Well, that's irrelevant. Once you say it's not statistically significant, that disappears. You can't even write that. I don't know why they wrote that in the Bone and Joint Journal of 2015. Mean functional scores did not differ significantly. So no difference between plates and screws. And the only thing they found different was rotation. And they said that that was significantly better. Well, let's have a look at this rotation. The only values that are statistically significant, P values are in bold, so we can take our flexion and extension as you would expect, and that leaves us with a little bit of rotation. And so they talk there of an arc of movement of 18 degrees between 152 and 134. Now, I don't know about you, but unless you're a professional, I don't know, have to use a screwdriver every day, it's very seldom that you have to use an arc of 152 in any of your activities of daily living. And of none of the stiffness protocols or outcomes have they ever said, you know, this is your arc. There's the study from the 80s, there's the study from the 2000s, looking at how much pronation you need and how much supination you need. And in fact, with either plates or screws, you'd get there. And most people, what they don't want to do is rock backwards and forwards all the time. They want to ask for change. So you can get change with supination of 72, or they want to show the back of their hand to look at their nails, and you can type with a pronation of 30. And so 62 is more than enough. So although there is roughly 8 degrees of pronation and supination, that's what it all boils down to. So you've got a case report and 8 degrees. So let's just put to the test the Van Rieck classification. I like it, but let's put to test the Crocodile Dundee classification. Is this a knife or is this not a knife? Let's face it, that's not a knife. That's a butter knife, man. I wouldn't take that on. Now that is a knife. Don't you love how the comminution is running down the neck? No doubt in my mind, that's a knife. And if you've got a knife, you need to plate it. I do like the Van Rieck classification because it brings into us the importance of the looking into the whole elbow. Here we see ligamentous laxity on the medial side. The lateral collateral ligament is had to be repaired. And so I like the Van Rieck classification, but I love the Crocodile Dundee classification. Is this a knife? Isn't this a knife? Well, we see how the radial head fracture is tucked out the back, a common pattern, but we see how the neck is still attached to the shaft. And so let's face it, that's not a knife, man. This is a winner-winner chicken dinner. This is every elbow surgeon's dream. The simple, one big piece of radial head. Now it gets a little bit more difficult. Is this a knife? Isn't it a knife? Recognize that pattern yet of that radial head tucked at the back of the capitellum. But we see how, closer look of these radiographs, how the anterior fragment, relatively small, is disconnected from the shaft. And so unfortunately, sometimes in life, things aren't black and white, and there does come a little bit of gray. This is the one that possibly you could be tempted in towards the dark side of using screw fixation. But I would always want to make sure that I had a plate next to me, because you open up these and you find that one piece turns into two, two turns into three, and before you know it, you can't fix it with screws. But you might be able to get it with a plating system. So always have that on the side of you. And this one for me is the gray zone. So in summary, when do you use screws? This is what it's all about. You use screws if you fix sore bone. They're great for fixing sore bone. You fix the screws if you're fixing cadavers. Use screws if you want a publication, because it's topical. You use screws if you fix fractures that don't need fixing. You use plates when they need to be fixed, when they're comminuted, turn the volume down a little, and when there's instability. And that's probably when you do need that Van Rieck classification to augment the Crocodile Dundee classification, which helps you decide whether to use screws or plates. Thank you.
That's it. If I have a conflict of interest, I'm sometimes a paid speaker with Acumet, but not today, obviously. So this is Lee. When we last met at the Royal Society of Medicine, you all know Lee as an excellent elbow surgeon, especially when it comes to trauma. There are not There's probably not many people that are better than him. And I'm so happy you used this phrase, Lee, because you know, gave me this header, winner, winner, chicken dinner. This is what I learned from Mr. Lee van Rensburg. But obviously, plating is not a winner, winner, let alone a chicken dinner. There are several mistakes that can be made. Lee didn't talk about this too much, but not all surgeons are as good as him, and some put the plate in the proximal radial joint. Others may have a slightly more subtle mistake, but still the patient can't rotate. And this one is just a plate. It's not strong enough. It turned into a non-union, and the plate broke. This is one of mine. Actually, the last one I did about 8 years ago, and avascular necrosis, probably because of the abundance of hardware that I put in. So here's Lee. This is his headshot from Cambridge. Last time I saw him, like I said, was in London, and he was sporting a great, glorious mustache. So I actually thought that with the lockdown, you would look like this now, Lee. Unfortunately, you shaved, probably yesterday. So Lee is the king, like I said. He's the king of elbow trauma. And unfortunately, after this talk, people will look at you not like this, but they will look at you like this. So we know that radial head fractures are the most common elbow fracture. You get it from falling in your outstretched hand in slight flexion and pronation. This is a treatment option. These are the treatment options, conservative or surgical. And when you do surgical treatment, you use screws. You can resect parts of it, or you can resect the whole thing, or you can replace it with the radial head prosthesis. I don't want to be too mean, so I've also listed the indications for radial head plates, and they're all in this slide. Sorry, I went too fast. So I'll show you this one. This was the last one of my radial head plating. I think this is a fair indication in Lee's classification. This is definitely a knife. The fracture runs into the neck. It's actually displaced in multiple pieces. And we put a plate in. I even used a little drill bit that I broke off, obviously deliberately, to get extra fixation, but it didn't work. It did fix a little bit. It got avascular. It turned into a non-union and a disaster, and it ended up like this. And why am I not calling this an indication of radial head plate? I should have used a radial head prosthesis straight away in this patient. He would have been much happier. The result would have been much better. So what does literature say? And Lee went over most of the papers that I used as well. There's not that much literature on it. Early literature talks about non-anatomical plates with reasonable results, but often one or two cases, or maybe a few cases in there. One of the surgeons talks about tucking the plate underneath the radial head so it doesn't impinge. So impingement was a problem even in the early 80s and 90s. Patterson did a biomechanical study, and even though it was a biomechanical study, this was figure 1. So it shows all the problems that can happen with plates. So they started looking at the strength of plating and found that a 2.7 millimeter blade plate, at the moment we don't use them anymore, but we use locking screws, is probably strong enough to fix the radial head, whereas all the other ones, the little hand plates, they just simply don't work. He K'd out all. Use double plating like some people do now in the Electronon. 10 patients, not bad, pretty good range of motion, good Mayoral performance scores. The plates were removed in 9. I thought it was quite funny that they didn't remove them in all because one patient refused to have a second surgery. So, you know, maybe they didn't need to be removed in the other 9 either. Klaus Burkhardt showed that none of the available plates, anatomical, we call them anatomical plates, none of them fit. Janikala also showed that it doesn't fit. The radial neck is simply too, there's too many variations in the radial head and neck for plates to fit to the neck and the head at the same time. Klaus Burkhardt, we also already saw this. I totally agree with Lee. It's not a knife. This can be fixed with easily and definitely not with the plate. And I also agree with Lee in this case. You know, if you are publishing something, use your best photos. And if this is the best one, I would definitely not have fixed this. 6 plates were removed. Grunline, 8 plates were removed. Raven, 8 complications, big complications, 3 avascular necrosis, 3 implant failures, excuse me, and 2 nerve injuries. One patient ended up with a total elbow replacement. So probably not from the radial head fracture, but from the associated injuries. Kruska 2019, very early, 41 fractures, probably the biggest series so far. Again, if you look at figure A on the left, definitely not plate material. Figure A on the right probably is, but then look a little bit closer at figure E. The screws are too long. So if you plate it, look at the way you're doing it. That's not a proper one. 11 plates were removed. More than 1/3 needed extra surgery. So that's huge. Then finally we get to a more modern era. Giffen showed there's no difference between plates and screws in fixation. Maybe if you have an axial deficiency, so most of them will have that. If you have a radial neck fracture, the neck will be impacted. Maybe then screws are not as good as plates, but in their study there was no difference. Smith, this is Adam Smith from Mayo experience, not very impressive. 14 complications from 19 elbows. Doesn't really go towards me, although there was 10 plates and 9 screws and didn't find the difference between groups. Again, 7 reoperations. So are these so difficult? Maybe they are so difficult. We already saw this from Lee. Stiffness is the same. Medial to lateral deviation, screws are slightly better. Hebgets, we already saw this one as well. Actual compression, no difference, plates or screws. Then I love this study, although Lee went over it very, very quickly. 41 Mason type 3 or 4 fractures, 16 screws, 12 plates, 13 prostheses, more complications with plates, 50% versus 19%. And you can say that's maybe not statistically significant, but 1 in 2 complicated surgeries, that's not very good. So we can debate that we're not sure who's winning yet. You know, we both use the same literature to prove our point, and obviously screws are better, that's for sure, but I don't think I've proven that yet. We don't know who's winning. I think the next slide, if you're not convinced yet, this should convince you. This is not my best and my smallest incision on the right, but it is one that's true. And this is the way you use screws. Put a plate in, you have to almost release the LCL complex completely. The annular ligament is completely ripped and torn away from the neck. This is not done on the right. And then for the non-believer, because I know Lee, I can see Lee shaking his head. I'm not sure if you can see that, but this is the video. So displaced radial head fracture, blocking rotation. We don't do anything to lateral ligament complex. We then reduce the fracture and put 1 or 2 screws in. And that's an actual case, and it's not an abnormal case. We then close the annular ligament, and that's it, it's done. So hopefully the 35% who voted plates earlier on are now voting screws. I actually made a mistake because I voted for screws, and then I thought, oh no, I shouldn't have done that. I should have pretended to use plates and then vote for screws after, but I forgot. This is one of Lee's winners chicken dinners. Displaced radial head fracture. Screws for sure. I know Lee's going to use screws here as well. No one, and hopefully no one in the audience will plate this. They do great. This is 2 weeks post-op. Nearly full range of motion. With a small incision, they really don't suffer that much. This is one where we used, where there was an extension in the neck. I just showed you all the cross type screws, but like Lee showed us, you don't need that many screws in the radial neck. As long as it's stable, and it is stable in most cases after 1 or maybe 2 screws, then you don't need many screws. And we don't want the screws to protrude into the radial tuberosity or to the side of the radius. Here's another one, a recent case, big fracture fragment. You see the extension in the neck, 1 screw again, 2 screws in the head, and this heals without any problems. This is a recent one. Again, a small extension in the neck wasn't too bad. We put as many screws in as you need, but we usually don't need that many. This is 6 weeks post-op. We saw him this week or last week. He's still wearing his corona mask. And they do great. This is slightly more difficult. So this is turning into a knife. If people don't believe that this patient cannot rotate, look at the left image. The little fragment is caught behind the left sigmoid notch. So this patient can't rotate, and actually looks pretty bad. We don't have a lot of hardware. We don't have a lot of hardware to work with here, because you see the comminution in the center of the radial head. So if you put a big plate in, first of all, if you put a plate in this one, it has to be very proximal. So it's going to interfere with your radial, with your annular ligament. You can't use one of those fancy distal plates because it will definitely interfere. Very, very simple fixation through a small incision once again, and patients do great. This is non-union. We can talk about whether you need to do something here, but this is symptomatic non-union in a professional who can't use his arm at the moment. He's very, very busy. This is the video of his fixation. The incision is obviously slightly bigger because of the non-union. We need to get to the base of the neck, but we don't need to go all the way through the neck towards the interosseous nerve. This has nothing to do with the debate, but I really like this. It's a biopsy needle, and you can get a little biopsy from the olecranon. It's already there. You don't need to go to the pelvis and destroy people's gait. Just get a little biopsy needle, and you get these really nice cylinders of bone that you can then use as bone graft into this, in this case, in the radial neck. Obviously, it won't work if it's a full-on distal humerus fracture, but in little fractures like this, you can use this. Lee will probably say, well, you don't need any fixation at all. As soon as you put the bone graft in, you can just leave it like that, and you probably could, but we want a little bit of compression so the bone graft doesn't disappear after a couple of days. Put it in. This is a nice little trick. So if you don't want to be bicortical, just put your guide pin back into the screw. If you're not sinking into the soft tissue, then you know that you're not bicortical, because it's very difficult to find your little pinhole again. But if your screw is bicortical and then you put your pin back in, you'll fall into the soft tissue on the other side. That's a very important trick as well when you're doing radial head fractures, because you definitely do not want to be too long with your radial head screws. This is the patient. Unfortunately, I only have a 6 weeks post-op. I tried to get him back to clinic. He didn't want to because he's not symptomatic anymore. So Lee, for the sake of argument, let's assume it healed and it's great now.
Yeah.
This again is a knife. This is a very recent case, 2 weeks ago, Montaggio fracture dislocation. There's no doubt that this needs surgery, if only for the proximal ulna and the coronoid fragment that's fractured. The radial head doesn't look too good. I told the patient that maybe we need to use a prosthesis, because when we have a Montaggio fracture dislocation, I want the radial head to be strong. I really want it to be strong, because these patients need to start moving straight away. If I need to protect the radial head fracture, then the result of the surgery will be very poor. So I want these patients to start moving. She's only 29 years old, as you can see on the left. Bad fracture. We went in. This is a fracture again. Doesn't look too bad on the 3D. I thought, okay, that's a big piece. So maybe that's something we can do. I don't have a good video at least. This is an approach that Lee likes. The elbow is completely dislocated. It's a big incision. Some surgeons need big incisions to feel big. I don't, obviously. Fix it. 2 screws in there, a couple of screws in the coronoid, and then a plate on the ulna. You see, we transosseous sutures. We reattach the annular ligament, and in this case, you can't dislocate the elbow without disturbing the LUCL. In this case, we cut it away from the bone as well, and we put it back on with our transosseous sutures, and this is the result. Not perfect. Articulation is perfect. The neck is maybe not perfect, but it's extremely stable. So there's absolutely no need for a plate, even in a fracture like this. Obviously, she has an olecranon plate, but that's it. It looks a bit weird because of the screw that goes into the coronoid. You can see it's not completely reduced. There's still a little bit of impaction on the radial neck, but this is something that Lee would call a butter knife and would not touch with his instruments. This is now 2 weeks post-op. I saw her this afternoon, and this is a rotation of 2 weeks. So Lee, again, I think you're the king. Hopefully people won't look at you like this, but I think they will look at you like this, like the badass you are. I love preparing for this. I know you're happy for me too. It's very clear that I won, but I know you're also happy for me to win this battle, and I appreciate that. Thank you.
Yeah.
Roger, that was fantastic. Thank you to both of our speakers today. So before we start taking questions, I'm just going to put up the poll that we put up at the start. And the question I will ask you this time is, has Lee convinced you to follow your inner Obi-Wan, or has Roger turned you towards the Darth Vader? Looks like a landslide, this one.
I'm really nervous.
We'll just give it a few more seconds, let everyone have a vote.
Yeah, our entire nursing staff and secretaries are voting as well.
Fantastic.
So hopefully they're voting
No
for me.
poir, please. Let's remember. Yeah, come on. Eurovision, come on.
Okay.
You're going to give it all to Belgium. What's the...
We'll give it 5 more seconds, guys. Okay.
Ireland give 10 points.
And the answer
Sammy,
is...
10 points.
Here we go.
Yes, very clear.
Mr. Sammy, what are you doing?
I'm just going to take a picture. Hang on. Don't get rid of it.
Yeah.
So we've all officially joined the
He
Darth.
wins.